I'm Dawei Yang from Beijing Friendship Hospital, Capital Medical University, and I'm an abdominal imaging radiologist. Today, I will introduce two topics. The first one is the imaging of liver cirrhosis. Okay. For the first topics, I will introduce from two aspects. First, I will introduce the concept of cirrhosis, and then I will spend more time on imaging features of cirrhosis. So, a question: what is cirrhosis? Cirrhosis is an advanced stage of chronic liver disease caused by repetitive liver injury and cumulative damage. And it is characterized by complete replacement of normal parenchyma by regenerative nodulars surrounded by fibrotic glands. And the cirrhosis may be accomplished by profound alterations in the hepatic microcirculation with the formation of abnormal macroscopic connections between hepatic arterial and portal venules, so-called APS. And it also can cause variable loss of hepatic function depending on the severity of parenchymal damage. And what is the etiology of cirrhosis? The causes of cirrhosis and their prevalence vary from place to place. In Asian-Pacific region, the most common cause is HBV, hepatitis B virus infection, and followed by alcoholism and NGHİ. And in Vietnam, that I found the documents from the published by the Ministry of Health of Vietnam, that alcoholism, HBV, and HCV infection may contribute a lot. So what is the gold standard for diagnosis of cirrhosis? Is liver biopsy. However, despite its universal use, the liver biopsy is an invasive and inaccurate gold standard with many drawbacks. For example, sampling error, risk of severe complications, and significant intra- and inter-observer variability in the assessment. So all this makes the liver biopsy not be a realistic method to perform for all patients. So non-invasive assessment of cirrhosis is essential for the routine clinical practice. And the second one is imaging features of cirrhosis. So does all cirrhosis have significant abnormalities? Let's see this case. For example, this is a 22-year-old male patient, and a big mass was incidentally found by ultrasound in the red lobe, and then he come to our hospital to take the contrast-enhanced CT scan. We could see a big mass in the red lobe. Due to his rapid wash-in, wash-out, it may be a malignant tumor, maybe HCC. But however, it doesn't have any high-risk factors. It doesn't have any HBV or HCV infection history. And also, from the imaging, we could see any evidence of cirrhosis. You could see the liver surface is so smooth. So this patient take a surgery, and after all, the big mass was pathologically confirmed by as a HCC in the red lobe. But so interesting, cirrhotic change in the peripheral region of HCC was also confirmed. So what does that mean? It means that cirrhosis may appear normal at imaging, since the nodulars and scars may be tiny, weeny, may be imperceptible. So I want to notice that a normal appearing liver at ultrasound, contrast-enhanced US, MRI, or CT doesn't exclude cirrhosis. But for most cases, cirrhosis may appear typical abnormalities, including 6 aspects. I will pay more attention to introduce it. The first one is First aspect was morphological alteration. And the morphological alteration may cause surface nodularity, global atrophy, segmental volume redistribution, and parenchymal contraction. Let's see. The first, surface nodularity. The left picture is a normal liver. In comparison to the normal liver, we could see the cirrhosis of the liver. The shape of the liver is changed. The surface of the liver is not smooth again. It becomes nodular. And also, we could also see the surface retraction here. The surface nodularity is caused by the presence of regenerative nodules immediately on the liver capsule. It has a high specificity but low sensitivity for early cirrhosis diagnosis. And another one is global atrophy. The left one is the schematic diagram. From this, we could see if the cirrhosis happened, it may cause the liver volume become smaller, like this one. And also, we could see the expansion of the space between liver and anterior abdominal wall, and also expansion of the gallbladder fossa and the ligamentum tear space here, indicated by the green arrowhead. And the cirrhosis may also cause segmental volume redistribution. In this case of cirrhosis, we could see the hypertrophy of a caudate lobe. However, the left lobe is atrophy. And here we could see the atrophy of segment 4 and the enlargement of segment 2 and 3. So the volume ratio between the left lobe and the right lobe changed. And here we could see the anterior lateral flattening. It's not smooth again. It becomes so flattened. Besides, parenchymal contraction could also be seen. Just as what I said before, here is the liver surface retraction. It's not a convex, it becomes concave. And also the notching of right posterior lobe could be seen on this CT image. In some cases, liver surface retraction is associated with areas of confluent fibrosis. Okay, the second aspect is the parenchymal alteration. And cirrhosis may cause lots of parenchymal alteration, includes cirrhotic nodulars, great fibrotic scars, confluent hepatic fibrosis, non-specific parenchymal heterogeneity, and fat infiltration, iron deposition. Let's see the first one, cirrhotic nodulars. For some case, that is the cirrhotic nodular and scars, tiny, weeny, it may not be discernible on imaging, such as here. For this case, you could see the discrete parenchymal nodulars are not discerned. However, for most cases of cirrhosis, numerous parenchymal nodulars could be seen in the liver background. Here we see numerous nodulars of variable size, signal, and enhancement that represent different types of cirrhotic nodulars. For example, regenerative iron, dysplastic nodular, and hepatocellular carcinoma. We could see here is a nodular that is hyperintense on T2 weighted imaging and hyperintense on T1 weighted imaging, but it shows wash in, wash out, and enhancement capsule. It is HCC. And the rest of the nodular in the liver background may be RN or DN. And the great fibrotic scars. Fibrotic scars is always surrounding the cirrhotic nodulars. It's usually imperceptible on ultrasound. However, it may be visible at a CT or MRI as a diffuse lacework of thin bands. These fibrotic scars may show mildly hypointense on T1 weighted imaging and hyperintense on T2 weighted imaging and high B-value DWI. So after contrast enhanced administration, it may show progressive enhancement and becoming hyperintense in the protovenous phase and the delayed phase, just like what we see here. And the confluent hepatic fibrosis, it is more commonly seen in cirrhotic caused by PSC, PBC, and alcoholism. It is characteristically pyramidal or wedge in shape with concave borders, just like what we see here. It is not round or oval, and it radiates from the hilum to peripheral. It shows similar intensity and enhancement as fibrotic scars we have mentioned in advance. And here we see the wedge-shaped confluent fibrosis, high intensity on T2 weighted imaging and DWI, but hypointense on T1 weighted imaging, and it shows progressive enhancement. And here it causes the liver contraction. But not all cirrhotic liver may show significant features. For some cases, it may show non-specific parenchymal heterogeneity. That's the case shown here. It just shows heterogeneous intensity on T2 weighted imaging, T1 weighted imaging. And after contrast enhanced administration, the parenchyma may appear different enhancement in the liver. The third aspect is the vascular alteration. Cirrhosis may cause vascular alteration that involves the hepatic artery, portal vein, and the intrahepatic vein. For the hepatic artery, it may become enlarged and tortuous. And for the portal vein, it may cause the portal vein dilated. And in some cases, the caliber may be reduced with long-standing reduction in portal flow. And also thrombosis and sclerosis may also be seen. And also the distortion of the intrahepatic veins, including narrowing of the intrahepatic cover and the hepatic veins. Let's see the case. Here, this picture shows the intrahepatic artery abnormalities. We could see enlarged and tortuous hepatic artery and its major branches. And here, it is a cirrhosis with portal hypertension. We could see the esophageal varices here and dilated portal vein and thrombosis inside. And also dilated splenic vein and thrombosis inside. And for the intrahepatic vein, it may appear abnormalities in cirrhosis that are caused by specific causes. For example, Budd-Chiari syndrome. We could see the stenosis of intrahepatic cover and the occlusion of post-hepatic cover in the DSA images. And also, the occlusion of left and lobe hepatic vein could be seen on the MRI imaging here. And the liver function alteration. The cirrhosis could cause the liver dysfunction. The abnormality in liver dysfunction may mainly caused by the reduced expression of hepatocyte bilirubin transporter, also named OATP. And another one is the preserved or enhanced expression of hepatocyte non-specific transporter, also named MRP. According to the severity of liver dysfunction, the altered imaging features could be seen on hepatobiliary phase. the short name is HBP. In detail, it will cause the diminished enhancement of the liver parenchyma and the preserved or diminished enhancement of the bile duct. So here are 4 pictures. The left one is a normal liver. We could see that the liver shows remarkable enhancement, and which is greater than the intrahepatic vessel. The vessel here is so dark. And also we could see the higher intensity in bile duct. However, when the liver appears dysfunction, the enhancement of the parenchyma will decrease depending on the severity of the liver damage. For example, the mild liver dysfunction, the enhancement of the parenchyma might just minorly greater than the intrahepatic vessels. But in severe liver dysfunction, the enhancement of the parenchyma is just similar to the intrahepatic vessel. We couldn't see the vessels shows dark imaging inside the liver, and also no excretion in the bile ducts. And the biliary alteration. There are 2 types of biliary alteration. The first one is the peribiliary cysts, and the second one is the submucosal edema of gallbladder. The peribiliary cysts is caused by the cystic dilation of obstructed periductal glands, and it distributes that parallel to the large bile ducts and are located on both sides of the intrahepatic portal vein branches, indicated by the white arrow here. You can see so many high signal cysts along the portal vein branches. And it always shows hyperintense on T2 weighted imaging and have no enhancing walls. And it doesn't communicate with the biliary tree of the liver. And for the submucosal edema of the gallbladder, we could see the thickening of the submucosa due to edema. And the thickening of the wall shows a similar intensity and enhancement as fluid. After contrast enhanced administration, the enhancement of at mucosa and muscularies could be seen, but no submucosal layer enhancement. And the last aspect is the portal hypertension. Here is the schematic diagram that I cited from this paper. It clearly shows that so many dilated portal vein and portal systemic collaterals appeared when portal hypertension happened. And also, it may appear portal vein thrombosis and splenomegaly and ascites. Let's see some pictures about the portal systemic collaterals, and also called varices. Here is the esophageal varices around the esophagus, and here is the dilated left gastric vein in portal hypertension that caused by cirrhosis that could be seen in normal condition. And here, the white arrow indicates the recanalized para-umbilical vein within the ligamentum teres spaces and extending from the left portal vein to the umbilic here. And this picture shows the splenomegaly and the splenorenal shunt and the gastrorenal shunt. The red arrow indicates the gastrorenal shunt that connects the left renal vein on the bottom and the gastric vein on the top. And the splenorenal shunt, it connects the left renal vein on the bottom and the splenic or perisplenic vein on the top. And also the left renal vein become enlarged. And the cirrhosis may also cause splenomegaly and ascites, like what we see here. The vertical height of the spleen is about 18.2 centimeter. Is much greater than the normalized standard, and also we could see a large amount of water inside the peritoneal cavity. And also, Gamma-Gandhi body could be seen in the spleen, especially in the cirrhosis caused portal hypertension. The Gamma-Gandhi body are small deposits of iron and calcium within fibrosis and elastic fibers in the spleen from microhemorrhage due to the portal hypertension. And on MRI imaging, we could see numerous foci of signal void, more pronounced on the longer echo GRE sequence. Yeah, here we could see numerous dark in the spleen, which become darker and larger on the in-phase T1 weighted imaging in comparison to the out-phase of T1 weighted image because of the longer echo. And also it is hyper-intense on T2 weighted and weighted imaging and diffusion weighted imaging, and it doesn't show any enhancement. So here are the knowledge I want to introduce, and the take-home message. Cirrhosis is an advanced stage of chronic liver disease caused by repetitive liver injury, and non-invasive imaging techniques play an important role in diagnosing of cirrhosis. Cirrhosis may appear normal at imaging since the nodules and scars may be imperceptible. However, for most cases of cirrhosis, typical imaging features could be found, including the 6 aspects that are presented here: morphological alteration, parenchymal alteration, vascular alteration, and liver dysfunction, and biliary alteration and portal hypertension. Familiarity with the imaging features of cirrhosis can be helpful for its diagnosis and treatment. So here is my first topic. Thanks very much.
谢谢老师Chang. Is correct. Tôi vừa học được câu tiếng Trung Quốc. Bởi vì giáo sư Chang sẽ về Trung Quốc sớm, sẽ bắt đầu với bài thứ hai. Nếu chúng ta có câu hỏi, câu thảo luận thì chúng ta có thể thảo luận sớm. Thế thì có thể chắc là you can continue with second part. Now you want to continue with second? Yeah, okay. Thì giáo sư Giang sẽ nói luôn cái bài về tăng áp lực mạch cửa cũng liên quan đến xơ gan, thì để chúng ta tiện theo dõi mà chúng ta có câu hỏi thì sau đây chúng ta hỏi luôn để please.
Okay, thank you very much. And the next topic I want to introduce is imaging portal hypertension. For these topics, I want to introduce from 4 aspects. The first, let me have a review of the concept of the portal venous system. So, what is the portal venous system? It is a vascular network that carries blood from the abdomen to the liver, like what we see in this schematic diagram. The main vessel in the portal venous system is the portal vein here, and which receives blood from the GI tract, including stomach, intestines, and also pancreas, spleen, and the gallbladder. The portal blood flow accounts for approximately 35% of the total liver flow. After processing in the liver's sinusoids, the blood then moves to the hepatic veins here and IVC, inferior vena cava, and then return to the heart. So About this portal hypertension, we should also know the radiological anatomy of the portal venous system. So this picture clearly shows the portal venous system. We could see the main portal vein is formed by the confluence of the SMV, superior mesenteric vein, and the splenic vein here, and also gastric vein and the cystic vein. And at the hilum of the liver, the portal vein splits into the left and the right portal veins, which we could also see on the CT image. And these branches further divide into smaller branches and traveling to different parts of the liver. As a radiologist, we should also be able to find the portal venous system on the cross-sectional CT image. Like what we see here is the left portal vein, and is the right portal vein. And here is the main portal vein. The diameter of the main portal vein is 1.2 centimeter, is normal. And here is the splenic vein, and here we could see the SMV and the IMV. Another important information is about the portal systemic collateral pathway. The portal systemic collateral pathway, also known as potential portal systemic shunts. The short name is PSS. These pathways are blood vessel networks that connects the portal vein on one hand and the systemic circulation on the other hand, causing blood to bypass the liver. So in normal condition, the portal systemic collateral pathway is negligible. What does that mean? It means that in normal condition, it doesn't work. It exists there after we were born, but it doesn't have any blood flow through it. So it is so tiny and weedy, and which we couldn't be visible at the imaging. However, when the portal venous pressure increases to a significant degree, the portal systemic collateral will divert blood away from the liver for reducing portal venous pressure, and it will become dilated and twisted, and could easily be visible at the imaging. So how many pathways exist in our body? Several, but the most common pathways are presented here. The most important one is the esophageal or paraesophageal collaterals. We could see from this schematic diagram, here is the main portal vein, and here is the left gastric vein. It connects to the esophageal and paraesophageal plexus. So when portal hypertension occurs, the blood was diverted from left gastric vein to the esophageal plexus, and then to the azygos or hemiazygos vein, and then to the superior vena cava, and goes back to the heart in the end. And the second pathway is the para-umbilical collaterals. So when portal hypertension occurs, the blood will be diverted through the para-umbilical vein. Here, the umbilical vein is invisible in normal condition, but when the portal venous pressure increases, it may be dilated, and then the blood will goes to the peri-umbilical vein plexus. It's just around the umbilicus, and then goes up to the superior epigastric vein, or goes down to the inferior epigastric vein, and goes to the superior or inferior vena cava in the end. And the third collateral pathway is the anal collateral. Here, it connects the portal-venous system with the superior rectal vein, and the blood will go to the anal canal vein plexus, and then goes to the inferior rectal vein and the iliac vein, and goes to the IVC in the end. So, knowledge of this portal systemic collateral pathway is a basement for us to understand the imaging features of portal hypertension. The third, I will introduce the concept of portal hypertension. So what is portal hypertension? Is increased pressure within the portal venous system. Portal hypertension is defined as hepatic venous pressure gradient. The short name is HVPG, more than 5 millimeters of mercury. And HVPG is a measurement of difference between the wedged hepatic venous pressure and the free hepatic venous pressure. Just like what we see here. Here is the picture to measure the free hepatic venous pressure, and in this picture is to measure the wedged hepatic venous pressure, and then we got the wave and the value. If the HVPG is more than 5 millimeters of mercury, it indicates portal hypertension. But if it is more than 10 millimeters of mercury, it indicates clinically significant portal hypertension. But when it is more than 12 millimeters of mercury, it indicates high risk of variceal bleeding. However, the measurement of HVPG is invasive, is costly, and requires specialized personnel and equipment. So, accurate and non-invasive method for the assessment of portal hypertension is needed. So many textbooks or papers give us the knowledge about the pathophysiology of portal hypertension. And these dedicated pictures I cited from this paper is helpful for us to understand how the portal hypertension caused and how it induces abnormalities. It is so sophisticated for radiologists, but we could spend more time to understand it. But more important we should know is the imaging features of portal hypertension that we could use to make a diagnosis of this kind of disease. The imaging features of portal hypertension could include aspects, the 6 aspects. The first one I think is the dilated or stenotic portal vein. Dilated portal vein. As we all know, that a normal portal vein diameter is between 7 to 15 millimeter. However, when portal hypertension occurred, the portal vein diameter may increase, and it is well accepted that the 13 millimeter or greater is a sign for portal hypertension. Like what we see here, for this case, the diameter of the portal hypertension, the portal vein is 1.5 centimeter, and for this case is 1.7 centimeters. However, does all portal hypertension have an enlarged portal vein? No. For some cases of portal hypertension, the portal vein may become stenotic. Like what we see here, the diameter of the main portal vein, the right branch and the left branch are all less than 13 millimeter. So portal vein stenosis or occlusion can result from that results from thrombosis or constriction or other causes can lead to portal hypertension. And also, the long-standing reduction in the portal flow may also cause the reduction of the diameter of the portal vein. And the second aspect is the portal systemic collaterals. Here is the portal systemic collaterals that I have mentioned in advance. So let's see what happens if portal hypertension occurs. The first is the esophageal and the paraesophageal varices. For this case of portal hypertension, we could see the esophageal varices here, and the paraesophageal varices here, and also gastric varices, and also the left gastric and the gastric varices on these coronal CT images. And in another case, we could also see the paraesophageal varices here. It shows dilated paraesophageal venous plexus. And here is esophageal varices is the dilated submucosa venous plexus. And here is the left gastric vein that we could see in the case of portal hypertension. It drains blood from the splenic vein to the esophageal vein plexus and is invisible in normal condition. And then second pathway is the paraumbilical varices. We could see the recanalized paraumbilical vein here, indicated by the yellow arrowhead. In normal condition, the paraumbilical vein is invisible on CT image. But when portal hypertension occurs, it becomes dilated and could be seen. It connects the left portal vein branch and then goes along the anterior wall to the umbilicus. And also we could see here in the surface between the left lobe and the anterior abdominal wall. And here is the picture of the paraumbilical varices on the coronal image. Here is another case that I cited from these patients. We could see the enlarged left and the right portal vein, and also the recanalized umbilical vein here. So it goes down and goes subcutaneous. And here, around the umbilicus level, we could see the periumbilical vein plexus that is dilated. And here is the reconstructed coronal CT image. We could see the dilated inferior epigastric vein, which has a name Caput medusae. So what is a Caput medusae? Caput medusae is a dilated and tortuous superior and inferior epigastric vein. Like what we see here. Yeah. Here is the dilated superior epigastric vein that is seen from the skin. And here, the red arrow indicates the inferior epigastric vein. The shape of the dilated epigastric vein is just like the hair of the medusae. So we use the name to describe it. And also we could see splenorenal shunt and the gastrorenal shunt in some case of portal hypertension. Here is the schematic diagram. In normal, the left renal vein doesn't have any branch that is visible. But in case of portal hypertension, we may see two branches on the upper margin of the left renal vein. And the number 6 indicates the gastrorenal shunt. And number 7 indicates the splenorenal shunt. So in the case of portal hypertension, we could see here, yeah, this is the green arrow indicates the enlarged left renal vein, and the red arrow indicates the gastro-renal shunt. It connects the left renal vein on the bottom and the gastric or short gastric or posterior gastric vein on the top. And another one is here is the splenorenal shunt, which is more close to the spleen. And also, we could see the anal canal varices. Also, the occurrence rate of this kind of varices is much less than the esophageal varices or para-umbilical varices. According to this picture, we could see the anal canal vein plexus. Here, it connects the portovenous system through the inferior mesenteric vein, and also it connects to the systemic vein system through the inferior renal vein. So, in some cases of portal hypertension, the anal canal varices could be seen. And the portal vein thrombosis. Portal vein thrombosis could be a cause of the portal hypertension, but also it could be caused in condition of portal hypertension, just like what we see here. Inside the portal vein, we could see the absence of enhancement. Here, it shows no enhancement. In different phases, the CD value doesn't change. And the splenomegaly and ascites. Portal hypertension may also cause splenomegaly and ascites. Just like what we see here in this case. Yeah, the vertical height of the enlarged spleen was 18.2 centimeter, is more than 12 centimeter, and also large amounts of fluid could be seen in the peritoneal cavity, and also Gamma-Gandhi body, which I have just introduced in advance. And the last one is the causes of portal hypertension. Besides, we make the diagnosis of portal hypertension. It is essential that we found the imaging features to discover the causes of portal hypertension. The etiology of portal hypertension is numerous. According to the disease, of the location of the disease, it can be classified into pre-hepatic, intrahepatic, and post-hepatic. And also for the intrahepatic causes, it can also classified into pre-sinusoidal and sinusoidal and post-sinusoidal. So the causes is numerous. Here we give some examples. The most common causes of portal hypertension is cirrhosis, especially HCV or HBV infection. Here we see the esophageal and varices and the gastric varices and the dilated left gastric vein, and is caused by the HBV infection caused cirrhosis. We could see the surface nodularity and the atrophy of the left lobe. And this case is idiopathic portal hypertension. We could see the evidence of portal hypertension, including the splenomegaly, the gastric varices, and the esophageal varices. However, there is no evidence of cirrhosis. For example, here we could see the enlarged caudate lobe, but the surface is smooth and no surface retraction, no expansion of the space. So there is no evident cirrhosis, and is confirmed as idiopathic portal hypertension. And here is a case of cirrhosis caused by the Budd-Chiari syndrome. In this case, we could see the esophageal and the periumbilical and perivertebral varices on the MRI imaging, and also splenomegaly. But the most important thing is that the occlusion of hepatic vein here, and the stenosis of the hepatic segment of IVC here. So is direct evidence of the Budd-Chiari syndrome. Okay, that's all I want to introduce. So the take-home message is the portal venous system is a vascular network that carries blood from the abdomen to the liver. And the post-systemic collateral pathways were foundational to the understanding of imaging features of portal hypertension. The imaging features of portal hypertension includes 6 aspects, like dilated or stenotic portal vein, portal systemic collaterals, portal vein thrombosis, splenomegaly, ascites, and also we should to understand the causes of portal hypertension. And the familiarity with these imaging features of portal hypertension can be helpful for its diagnosis and treatment. Okay, that's all I want to introduce. Thank you a lot.